Rural healthcare, a complex topic. Certainly in other venues, I'd be very willing to have further conversations, so either at county parties or other ad hoc gatherings where people would like to explore some of these topics further. So for today, we'll start with a brief history. And first came the nuns. In the late 1800s to 1950, the nuns came to northern Wisconsin. Things were fairly simple. If they needed a building, capital, they could pass the offering plate till they raised enough money to pay for the building. Once the building was operational, most of the labor was from the nuns who had taken vows of poverty, so labor costs were quite low. And the finances were actually also quite simple, pretty much run out of the shoebox in Mother Superior's office. When it was time to pay the utility bill, you saw how much cash was in the box. And of course, many of the patients would pay through bartering by providing produce, which came off the farm. But then, after World War II, there was a period of rapid expansion. First of all, there was a rapid expansion of knowledge because the National Institutes of Health was created. So there was a vast amount of research done to understand diseases and potential treatments. Employer-sponsored medical insurance became a standard part of labor negotiations and benefits to employees. Now, President Truman tried to set up national universal insurance through the federal government, but that was defeated. And from the National Institutes of Health and the resources and the research came diagnostics and therapeutics. Antibiotics expanded. There had been a few antibiotics available prior to World War II, but they greatly expanded in numbers and efficacy. Chemotherapy was developed, so cancer was no longer universally a fatal diagnosis. Complex surgeries became possible because of advancements in anesthesia and surgical techniques. Transplantation became possible, so when an organ failed, such as a kidney or a liver or heart or lungs, it did not mean the patient died. It meant that they got a new organ. And of course, dialysis came in, which treated a disease that had been 100% fatal, kidney failure, and after 1972, it became part of national health insurance. And then all of this comes together probably at its apogee, which is intensive care, where all of these inputs come to bear on the care of the patient with skillful labor, knowledge, diagnostics, and therapeutics. Well, to go along with this then, there needed to be the development of facilities. And so as opposed to just raising local funds, federal funds became available, and a major input of federal funding to hospital facilities were Hill-Burton grants. Basically, your town could get a grant for a new hospital as long as it desegregated. This was actually an early step in the 1950s towards desegregation of healthcare. And so the other change is that all of a sudden facilities needed to move their accounting from cash in Mother Superior's office to what's called accrual accounting, or the usual complex corporate accounting systems. And then the income change. So along with the employer-sponsored insurance, which was increased reimbursement for medical procedures, the federal government also reimbursed people who weren't covered under employer-based insurance through Medicare and Medicaid. And initially they reimbursed to what was deemed reasonable and customary, which translated into whatever hospitals and doctors said was reasonable and usual. And then beyond Medicare and Medicaid, community health centers were developed, which provided another safety net for patients to get primary care. So with this rapid expansion, instead of the capital to pay for the capital, the buildings, facilities, and equipment, develop a complexity that almost rivals a nuclear power plant in terms of cost and complexity. In order to finance this, long-term debt financing, usually through tax-exempt bonds initially, until we move into for-profit healthcare when it becomes selling in public tax share markets. Labor changes from being the people who took vows of poverty to being nurses who are now being paid, and of course physician salaries also significantly increased during this time. And then there's this new strata in medical care of medical administration. Supplies become more complex. In the era of the nuns, it was mainly linens and food, and now all of a sudden it's complex pharmaceuticals and other necessary supplies to care for patients. And the finances, now it is the management of long-term debt. And cash flow becomes quite complex because the service is delivered today, payment probably won't be seen for at least 30, often 90, and sometimes out to a year. And so during that period of time, while you're waiting for patients, payroll needs to be met, utility bills need to be paid. So management of cash flow becomes challenging. Now, all of this is what results in this administrative complexity. Well, the end result of all this is the cost of all of these endeavors rapidly increase. So in $1970, we were at $2,000 per person in the United States. By 2022, we're at $13,000. And of course, the payers take note of these increasing costs. So starting in 1980, there's attempts to control the cost of medical care. And the first is to move some of the risk, the financial risk, to the hospitals and to the doctors. And so for the hospitals, diagnostic-related groups, DRGs, are implemented. And so a hospital is paid a set amount based on the patient's diagnosis, not on the cost of care for treating that diagnosis. Health maintenance organizations are formed where the premium goes in and then the insurance companies actually enlarge to include the provision of the service as well, or HMOs, and so that there is a set amount of resource available to care for the patients. Medicare starts clamping down on the physicians by setting a fee schedule where they determine what the payment will be to physicians. And then there's the unleashment of the power of the marketplace through private enterprise. And this comes in, interestingly enough, under President Clinton with Medicare Advantage, to where we privatize the insurance portion of Medicare. So insurance companies now get the revenue from the federal government, and then insurance companies manage the care of the patient with the Medicare fee schedule. And Medicaid is the same situation here in Wisconsin. We have multiple insurance entities that manage the care of Medicaid patients, again, with the Medicaid fee schedule. Other attempts to control cost, prior authorization. So just because your physician says you need a procedure, well, now the insurance company has to agree. And if they do not agree before the procedure, they aren't going to cover the cost. And then the insurance companies become quite skillful at deciding whom to insure and whom not to insure. And so we end up with the not insurance people who have a high risk of actually needing medical care, and then shifting more of the cost onto the patients. And so there's an increasing amount of copays and premiums and the development of what are called high deductible health plans, coupled with health savings accounts, as they say, coverage for the healthy and wealthy. Again, interestingly enough, these were piloted in the 1990s under the Clinton administration. And as this complexity grows, consolidation then follows. Because in order to cover the cost of patients paid for through governmental systems, the hospitals and physicians need to maximize the amount of reimbursement they get from commercial insurance. So this is the cost shifting. So as the ability to cover costs just through Medicare and Medicaid diminishes, more needs to be shifted from the commercial payers. And so it becomes the art of the deal to have negotiating power. And so now what we're left with is entities like Aurora Advocate Atrium, which is a consolidation between Wisconsin, Illinois, North Carolina, South Carolina, all the way down to Georgia and Alabama. They're a $27 billion entity. They have 5.5 million patients. Why is this important? Because on the other side of the table is United Health Group, the 11th largest corporation in the world, with a market capitalization of $500 billion. So for Aurora Advocate Atrium to be able to tell United Healthcare, you have to pay us this much because we have all these patients who come to us, that's why they need to be big, because the other side of the table is big. Now, of course, United Healthcare Group's answer to that is fine. We'll just buy everything up, and so they're currently acquiring physician practices. Because the ultimate goal is to have providers, hospitals, and insurance all contained within one entity. So there again was a response to the response. Then there was the mitigating, how are we going to mitigate these adverse effects of cost control when people stopped getting the medical care they needed? Well, first of all, we developed favorable reimbursement for certain areas. So these are sole community provider hospitals, critical access hospitals, and provider-based billing, all aimed at making sure that communities don't lose their hospitals. We developed cost-based reimbursement for community health centers. So even if most of the care they provide is uncompensated, they get an extra revenue from the federal government so they can stay in business. And then we have the Patient Protection and Affordable Care Act come into being, otherwise known as Obamacare. So it eliminates the pre-existing condition part of risk rating. Premiums are subsidized up to 400% of federal poverty level. Medicaid is expanded. Turns out in Wisconsin, that's a complicated story, a talk unto itself. We already had pretty good Medicaid coverage in Wisconsin compared to many other parts of the country. And then there's an innovation center developed within the Affordable Care Act to test methods to see if other ways can be found to decrease the cost while maintaining the quality. So we have accountable care organizations and shared savings programs. Okay, so how does all this play out in the 7th Congressional District? Well, first of all, we have a lot of hospitals. There are over 30 hospitals, and there are dots here on the map, and most of them, you see, are CAHs, or critical access hospitals, which are, in fact, too small to fail. And so even if they only have an average census of 3 to 5 patients a day, the federal government assures that they get enough revenue from the federal government to keep the lights on and the doors open. So most of the hospitals in the 7th Congressional District are critical access hospitals. And then we have a few sole community provider hospitals. So that's the hospital in Marshfield. It's the hospital in Rice Lake. And so these are larger hospitals. They're kind of your typical community hospital, but because of the distance to the next hospital, they're deemed sole community providers. So they also get some added reimbursement from the federal government to make sure that the lights stay on and the doors stay open. And then we have some general hospitals, usually in areas where the hospitals are closer together, such as Wausau and Weston, or now in Woodruff and Minocqua. So we are well populated with hospitals. There are some zones you can see here in the middle of the state where the distance can be a little farther. If you're in Prentiss and Phillips, it's a bit farther, and certainly once you leave Park Falls, you have to get to Ashland to find the next hospital, and over in the northwest, distance between Hayward and Superior. So along with this hospital, assuring that these hospitals stay in business, we also have outpatient facilities that have substantial government support. So we have tribal clinics, we have rural health clinics, which again get favorable reimbursement for Medicare and Medicaid. And then we have the federally qualified health centers, so that's Family Health Center, Bridge Street Health Center, and then Northland Center are just some of the examples throughout northern Wisconsin. So we have significant governmental support for both the hospital side as well as for the outpatient side through federal government subsidies. So how does this finally all play out here in central Wisconsin? Well, if you take all these hospitals, and this is all publicly reported data. There's no inside information here in any of this talk. It's all publicly available. It's just tedious to pull it all together. So we look at the 7th Congressional District hospitals combined for 2022. So now we're post-COVID. There's no longer the inputs that were brought about through COVID. And what we see is that, first of all, where does the money come from? So the revenue. Well, about $1.3 billion comes in through Medicare. Another $300 million comes in through Medicaid, and then about $1.7 billion comes in through commercial. So about half of it comes in from the government payers, and about half of it comes in from the commercial payers. But not all payers are created equal. So every time a Medicare service is provided and the hospital charges out $1, the hospital gets on average 32 cents. If it's a Medicaid patient, the amount of payment after the hospital says, will you pay us $1? Medicaid says, we'll pay you 25 cents. With the commercial contracting, a little bit better. Say, okay, commercial payer, we want $1. The commercial payer pays 67 cents. So that's the percent recovery, a key number to track in terms of how medical care is covered. So when you roll all this up, how does it finally play out? At the end of the day, what you want to know is, did you make enough money to pay your bills and maybe have a little bit retained? And so the net patient revenue, after all the discounts are applied and all the percent recovery, $3.4 billion of revenue comes into the hospitals in the 7th CD. The expenses are just a tad below that. So the operating margin was $55 million, all rolled up. So that's a 1.6% operating margin in 2022. Now, one of the larger hospitals in 2022 had significant losses. So this number, if you try and track it, it's usually more around 3%. So the 1.6 was actually not such a good year, mainly just because of one particular hospital that had a significant operating deficit. But also when you're looking at this amount of capital that it requires, it turns out that's really not enough to have financial stability in the long term. It does get the lights paid, it gets the light bill paid this year. It doesn't necessarily mean that you have resource being put away to build the new hospital when this one wears out. So just to give you an example of how this plays out in other parts of the world. So Northern 7th CD, we have a very public supported healthcare system. So now let's turn to a less publicly supported healthcare system, and there's a for-profit hospital in Eau Claire, so our neighbors, just outside the 7th CD. So how does their world work? Well, in their world, so they received $22 million from Medicare for the services provided to Medicare patients. They only received $1.6 million from Medicaid, and their commercial was $82 million. So about a little over $100 million in rolled up revenue. Now, what do they get paid? Well, when they go to Medicare, as opposed to the 7th CD hospitals, they get 28 cents instead of 32 cents. So they, again, you can see where Medicare is stepping in to help the critical access hospitals. And then we look at Medicaid. So when they provide service to a Medicaid patient, they get less than a dime per dollar that they'd like to get versus the typical hospital in the 7th Congressional District that's getting 25 cents. And then, but in commercial, they seem to have good negotiators, so they get 72 cents on the dollar that they request. Now they're also, because they have no obligation to take care of anybody, their payer mix shows that they really try and keep the Medicaid patients pretty much out of their facility. It's a very low percentage of the services they provide. But some Medicaid patients get in the door. But how does this roll up for them? So they bring in about $110 million. They spend $71 million. They end up with a profit margin of 34%. Now, they're a for-profit hospital, so this 34% margin, of course, gets to be paid out in dividends to their shareholders. They're traded on the NASDAQ. So who's ever an owner of the for-profit hospital in Eau Claire is doing very well in Eau Claire with for-profit medical care. So in summary of this part, capital legacy was from federal grants, currently funded through tax-exempt bonds, and revenue in the 7th CD heavily supported through federal and state programs. But now let's turn to another key part. So we've got buildings and we got our bills paid, but now we need labor. We need people. Medical care is incredibly labor intensive. So in turn, the ability to have providers is tracked, and so we have health professional shortage areas. And you can see that in the 7th CD, we have areas which are deemed to be shortage areas. And so our scores, we do have areas that range 13 to 15, and then we have areas that range greater than 15. So those are areas that are deemed to be significantly short of medical providers. And just to give you one small case study, obstetrics, because this has a lot of interactions with other parts of our communities, because if you don't have obstetrical care, there aren't too many humans of childbearing age who are planning on being pregnant who want to live in your town if they can't get care for when they get pregnant. So nationally, there has been an exodus in rural hospitals from obstetrical care. And 267 hospitals, rural hospitals, discontinued obstetrical services in the decade from 2011 to 2021. And just in the COVID period alone, that was almost a fourth of those hospitals. And unfortunately, Wisconsin is fourth in line by the numbers. Minnesota was first, Iowa, Texas, and then Wisconsin. So 16 hospitals in Wisconsin during this period of time discontinued obstetrical care. Now in the 7th CD, we do have a number of hospitals that provide obstetrical care, but you can see again, there's significant gaps in the 7th Congressional District where it's at least a 30-minute drive to obstetrical services. And so, again, if a person is in labor and ready to deliver, that 30 minutes obviously can be fairly significant. So, how do we solve the healthcare worker problem? Well, there's various ways that we recruit healthcare. One is to train them locally, and some will stay. And so we have the Wisconsin Academy of Rural Medicine. Medical College of Wisconsin opened up a campus in Wausau about 10 years ago. We have residency programs, so we train people here after medical school. Again, some of those people will stay in northern Wisconsin if they train here. There was a national program developed about 1970 called the National Health Service Corps. Their graph is there on the right, and the number of physicians who were supplied through that, and certainly northern Wisconsin benefited, Ladysmith and Park Falls and places of that nature. And it rose during the 1970s. In fact, that was going to be my business plan to go to medical school because I started med school in 1981. Unfortunately, the American electorate chose otherwise, and they elected Ronald Reagan. And so right after about 1980, Reagan, to decrease cost to the federal government, pretty much wiped out the National Public Health Service Corps. So I had to find another way to finance med school. And you see that significant drop-off in the 1980s in the number of physicians provided through this program. And then as you march along, all of a sudden you get to about 2010, and you see that very nice hockey stick rise in participants in the program. That's the Affordable Care Act. So once again, we're back to doing that. But of course, then the other issue is, to quote the musical Hamilton, immigrants, we get the job done. So you see that of the physicians currently in the country, 25% of them are international medical grads. And certainly here in northern Wisconsin, if it weren't for people who went to medical school in a different country and then came to the United States and did their training and stayed, our physician group would be significantly depleted. But it's not just the physicians. Nurses also, significant number of people who are on H-1 visas and other visas who came to the United States as immigrants. And then more importantly, you go down and you see that people like home health aides and nursing assistants are also significantly staffed through people who were born outside of the United States. And certainly I can tell you, having been both a physician and a nursing assistant, at 2 in the morning when a patient is in the hospital and is incontinent, it's not the physician who's going to solve the problem. So that in order to staff up medical care in rural areas, we need 2 inputs. We need the federal government to support people coming here through the National Health Service Corps for people who are going through the United States education programs, and then we need robust immigration policy which allows people who went to medical school in other countries to train here and to stay here. So once we have all this money in the United States, where did the dollars go? So the data I'm showing you here is almost 8 years old. It was published in 2018. The author of the paper tells me that it is still current. So at that time, the per capita, I told you $13,000, that's 2022. When this was done, the per capita cost in the United States was $9,400. And we're going to compare us to Canada because they actually have better health outcomes than we do. So Canada, they're managed to take care of everybody and keep everybody even healthier than the United States for about half the cost, 49%, $4,600 per person. So certainly there's some easy targets. There's administrative cost, and that's all that insurance and all of it takes to get prior authorization. And yes, Canada basically can do it for 18% of what we do for the administrative cost, but even if we were at Canada, so we would take about $600 off of our healthcare costs, but we'd still be right around $9,000 per person. So it's not just our administrative costs that drive up our health care. So what's next? Well, we pay people more. So both the physician salaries and the nurses' salaries, Canada pays about 60 to 75% of what we pay in the United States. And so both physicians and nurses are paid more. And certainly in many small towns with rural hospitals, one of the better jobs is to be one of the nurses at the local hospital. And then we get to the issue of our capital and how we use it. So we're going to use a couple examples, MRI scanners and CT scanners, big pieces of very expensive equipment. So in the United States, we have 38 MRI scanners per million people. Canada gets by with 1/4 that, 23%. They have 23% compared to the number we have. They have 9 scanners per million, we have 38. But surprisingly, with those, they actually do, they do fewer scans per 1,000, but you can see that whereas they have only 23% of the number of scanners we have, they do 47% of the number of scans. In other words, they're getting twice as much output per scan than what we're getting in the United States. So they spend less on buying the equipment, but once they have it, they use it more efficiently. The same story plays out almost identically with CT scanners. United States, we have 3 times the number of CT scanners. We do just under twice as many scans per 1,000 people. But again, the Canadians, they buy fewer scanners, but they use them twice as efficiently as we do. And then, of course, the big one has been pharmaceutical costs. And yay for Democrats for the Inflation Reduction Act, for going after this in a meaningful way and lowering the cost of pharmaceuticals, because in the United States, we're paying $1,400 per person for pharmaceuticals, where the Canadians, again, same type of health care, paying $600, so they're getting it for half price. And then we look at other types of expensive interventions we do. So coronary artery bypass grafting and opening up heart arteries when people are having a heart attack, a PTCA. You look at it, and sure enough, Canadians are able to do fewer of those. Either they're healthier or they just have other indications, but they are able to do fewer of them. Well, I think giving this talk in 2024, I do need to talk about one of the elephants in the room of what happened to our neighbors next door in Eau Claire. And a hospital that had been there for over 100 years and took care of a significant number of people in the community closed. And this is a topic, another talk in terms of what all happened at Eau Claire. But let me just say in summary, the long-term national drivers of expensive care showed up there before the rest of it. Eau Claire has excessive amount of capitalization. There's just too much stuff taking care of too few people. You do have, I showed you the data for the for-profit hospital. That 34% margin means that resources are being extracted from the community that's not being used to benefit medical care in the community. There was COVID disruption in the labor market, which is still working its way through healthcare. The demographics have shown up, and if demographics is destiny, the 7th CD, we have a problem. And the safety net programs that keep the hospitals open in the rural parts of the 7th Congressional District are not available in Eau Claire. So the other issue to address is what's called social determinants of health, because it turns out we've talked all this stuff about medical care, hospitals, doctors, nurses, etc. Well, it turns out that's 11% of what keeps you healthy. Most of what keeps you healthy has nothing to do with the hospital or the doctors or the nurses. It has to do with the social determinants of health. And in rank order, it's individual behavior and then social circumstances. So healthy communities and healthy lives. Again, a topic that can be addressed and has larger policy impacts of how do we build healthy communities and promote people to have healthy lives. And so, unfortunately, rural health is significantly lower than urban health. And so we die sooner, and of diseases that have many behavioral and social determinants, such as heart disease and cancer and lung disease and stroke and suicide, rural residents fare worse than urban residents. So when you think about rural health care, it goes well beyond the walls of hospitals and clinics. It goes into how do we build healthy communities and how do we promote healthy lifestyles. So, in conclusion, rural medical care exists because of government support. We are heavily subsidized, and that's what keeps our hospitals open. Supporting immigration is going to be crucial to having the labor force that we need. There aren't enough U.S. trained professionals to staff up the hospitals and to attract them to smaller communities. Our capital costs need to be regulated. Wisconsin at one time had what was called certificate of need, which meant you couldn't just build a hospital because you wanted to build a hospital. You actually had to prove to the community. Think of it as a regulated utility. And so the capital costs is a key part of controlling healthcare costs. I think the other thing is to recognize the current pain points. High deductible health insurance plans continue to be a pain point leading to medical bankruptcy. Prior authorizations slow down care and hurt patients. The high pharmaceutical costs, fortunately, are being addressed. It's going to be a long road. And then certainly the work of the Affordable Care Act is not completed, because as people step over from 400% of federal poverty and above, they still have significant issues with premium cost. But also just want to leave you that a critical part of this is to build healthy communities and healthy lifestyles. Well, thank you for allowing me to speak to the 7th Congressional District Convention today. And like I say, I'm very open to people contacting me so that we can have further conversations and further discussions in other venues.